Okay, Susan, we are live on YouTube and we are recording.
Great, thank you very much, Olivia. So good afternoon, everyone, and thank you for joining our very first webinar of the year. It's in the series Health System Transformation and COVID-19. Our topic today is COVID-19 vaccine distribution, progress to date. My name is Susan McNeil. I'm part of the senior management team at RNAO, and I'm helping to co-host this session along with a team at RNAO. So just to let you know who's behind the scenes, we have Olivia Clay and Melissa Aziz, who are managing the logistics in the back end. Madison Scaini, who is in charge of social media today, and Madison is having support from Marian Zitch, our Director of Communications. We also have helping in the chat and with questions is Irma Jean Bainock, our Senior Policy Analyst at RNAO. So this is our plan for today, our agenda. Dr. Doris Grinspun, RNAO's CEO, is going to start us off and set the stage with where we're at today in our fight against COVID-19. And she'll provide some context for the discussion. Then we are delighted to have Dr. Dirk Huyer to provide some critical updates and outline the approach and the progress of COVID-19 vaccination. We'll take your questions and answer as many as we can today. And some of you did submit questions in advance that many will be answered during Dr. Huyer's presentation. And then lastly, we'll have Doris provide some final comments and outline any recommended calls to action. So I just wanted to point out that we have a chat box that you'll find in the bottom of your screen. So please type in your comments and ask your questions there, and we'll be monitoring and answer as many as we can. And we are recording this session. I'll turn it over to you, Doris.
Thank you so very much, Susan, and welcome everybody. Thrilled to see already 600 participants. I expect, Dirk, that you are going to be the one that wins the celebrity prize today, because I think you are going to be the one that breaks the 700. And so here you go, you deserve it. You deserve it for the amount of work and the incredible work and the long hours that you're doing, and also for listening. Not always being able to act on what we say for a variety of reasons, but listening to some of our issues. RNAO has been speaking out, as you know, from day one, from the first wave to all the time, including before the holidays, about not waiting until Boxing Day to do a lockdown. We have repeated that call again and again. In fact, this past week, we asked also for a curfew like in Quebec. Unfortunately, we heard today that that curfew unlikely will take place. And it is the view of RNAO that we will reach easily 5,000 cases a day, if not 6,000 by mid-February. The modeling will come, the Premier will make announcements about what they are, and I will share with you a little bit about what is it that RNAO is asking. We believe that we need to move faster and swifter if we are going to, in any way or shape, suffocate the virus, because it will take months and months until we will do that with the vaccine. So again, we will speak about that a bit more soon. We are asking, as you know, the 4 hours of care for seniors. That has been a campaign that we have issued for several months, in fact, for several years now and decades. And we are still waiting with that. And we augmented that with the national standards for long-term care. And we are in discussions with the Prime Minister office and with letters and with an action alert in terms of that. Just to bring you up to date on the national standards, basically what we are saying to the Prime Minister is we want an answer before elections, not only as an election promise, and we are asking him to put the funds in the transfer payments, and if some premiers do not wish to participate on national standards, they don't get the money, and the others that do get the money. We are also calling for a ban on evictions. You cannot really isolate, and you cannot really take care of yourself if you are thrown into the street, quite frankly. So it's a public health crisis, the issue of evictions, and you will see an action alert coming on that, but I don't want to use time for that because I want to leave all the time to Dirk. A Just Recovery for All is another one of the initiatives. We can move, Susan, if not, we will use too much time on this. You can look at all of this either in my blogs or you can look at this in the COVID-19 portal, and you will see a lot of the actions that we are asking. But what we are asking for the past week urgently is for immediate and complete lockdown with a curfew similar to Quebec, and not to start 3 days after the premier announces, but actually to start on the same day. No reopening of schools on January, and that did take place, so we felt we were hurt on that. What we need now to know is how the kids that are at home will be supported at home, both in terms of the emotional, social supports, the online classes, equally important, meals, if some kids were going without meals before, etc., etc. And also at the same time, what is being done parallel in the schools to ensure that the schools are safe when we reopen, including ventilation and including teachers being vaccinated, etc., which I hope Dr. Huyer can talk with us about that. Increased support for vulnerable populations. Not everybody can isolate at home if they live in a household that is not big and they live 12, 14 people there. So we need to provide that capacity. The issue of being able to provide sick days so people are not afraid and go to work sick, etc., etc. Full speed ahead with 24/7 vaccination in long-term care. We do not feel that long-term care was a priority, even though it's said to be one. We do not feel that. So we are asking that from now on 24/7, and there is plenty. There is an army of nurses in primary care and in home care, the same as doctors that are ready to support the vaccination. And by the way, are already in the payroll. Next one, Susan, please. So I want to introduce you to Dirk Huyer, and I want to say 3 things on his favor. Number one, which I just learned, and it's the biggest thing, so it came to the top, is that his nurse is studying, his daughter is studying nursing, so now you went up even more brownie points, Dirk. And I also want to say that in his position as Chief Coroner of Ontario, he made a very important decision on his own and came to us to talk about that decision, and that was to create positions for nurses to work in his office. And I know for a fact that interviews are going now because I know a person is interviewing, so kudos to you on that, Dirk, also. Thank you very much. And lastly, on the issue of taking on this mega job of being a member of the COVID-19 vaccine distribution and the lead person on the distribution itself. And we know that that was not your day-to-day work and that you have not left the other work. So for the effort that you are putting, and I'm sure for the patients that you're also putting in more than one way in that type of a role, thank you, and I leave the forum with you now. And you do have, I told you, you will break you already have 700 people, so here you go. They didn't come because of me, I can assure you they came because of you. Go for it.
So thank you very much, Doris, and it's greatly appreciated your introduction. And we've worked together in so many different ways over the years, and it's always an honor and a pleasure to be working with you. And it's a real honor to be here. Doris has been sort of taunting me all weekend by saying the numbers that would be coming. And I said I was going to have a team come with me, and the team is very busy with lots of other things. So Doris just continued to laugh every time I said that I'd be doing this by myself. So in all frankness, thanks for letting me come. It's a very serious topic and it's a very serious time, but some of you who know me, despite that, always try to have some lightness to the work that we do, while clearly respecting and understanding the significance of the challenges. And Doris has hit on some of the very, very difficult times that I've seen, both in my work as the chief coroner, but also my work in doing some additional duties in the area of COVID. As Doris pointed out, people will say, well, why is the chief coroner doing this? And that's a really good question, because sometimes I ask it myself. But I think what I have in my coroner's role is I have a provincial perspective. I have intersection with multiple different disciplines, multiple different professions, multiple different areas of the province. And so I bring a coordination role. I don't necessarily bring a substantial expertise in public health. I don't bring expertise specifically in vaccine, but I learn about those things, and I have many different experts that teach me and support me, and then I will turn to them when I need additional help and when there are actually the people who should be doing the work. So some of the questions we'll answer. Some questions I might have to take back, and then we'll bring back to the group as we speak more through this. So what I wanted to do today is provide a lot of opportunity for questions. But I want to take you through some thinking around vaccines, some thinking about the prioritization work that we're doing. I saw a lot of the chat numbers or chat questions coming up about when will we be vaccinated. And what I'm thrilled, and then again, thrilled at a tough time, but still thrilled that people want the vaccine, that people are pushing for it. People want to be vaccinated. Clearly, there's importance to understand. Important for people to think about this, important for people to make their decisions in the most informed way possible. And I'm hoping today that I'll give you some information to think for yourselves, but importantly, because you're all leaders, how you will lead within your organizations, within your practice, within your families, within your friend group, within your communities. So hopefully there'll be some help for all of that. So if we move on to the next slide, next slide after that. So this is a slide that you can read later. These materials will be available for you later, as I understand, and everything's recorded. And I think I'm actually live in a variety of places. Hi, everybody. So what is an mRNA virus or vaccine, and how do they work? Well, the reality is what this is it's a little bit of genetic material, and those of you know all of this, but a little bit of genetic material that's embedded in it's a nanolipid, and so this vaccine is embedded in this fatty material that then can enter into the body, and that fatty material allows it to cross into the cells, similar to what other viruses would do. But this is not a live virus. This is just a small piece of the genetic material that goes into the cell, and as would other things that happen, the body does this all the time. This is nothing different than what the body does in other viruses and other situations, is it makes a product, it makes I'm just trying to think of the way to describe it. It makes a protein that is the same as the spike protein that's on the coronavirus. So it's what you see in the upper left of the diagram. You can see the little spikes on the outside of the virus, and that is what our body makes from that mRNA. So the mRNA goes inside the body, it makes that spike protein, and then it sends it out, and then the body's immune system responds to that. And that's then builds up the antibodies, but it also builds up the memory in the T cells, where they will then, when they see that spike protein again, will be able to develop the response very quickly and then eliminate and stop that virus from doing any infection. So this work has been researched for years. It has not been in a vaccine that's been brought out to the public at this point, but there's been much research into this, and so this is nothing new. This has been going on for years, and that's why they were able to do things. And it's also a fairly easy vaccine to make. And so that's how we're seeing so many doses come so quickly. And what the companies did is, anticipating that they would have approval, not for sure, but anticipating that they made vaccine in advance, as I understand, and then were able to release that fairly quickly. So I'm not going to go into much more detail about this particular slide. We'll move on to the next one. It's fairly detailed, but you can read it, as I say, later. So what are some facts? Well, people say, can you get it? Well, the answer is no. You cannot get COVID-19 from this. This is not a live virus. This is not a killed virus. This is just a piece of the RNA that allows our cells to make a protein, which is the which is the same as a spike protein, and then react to it. There is no intersection or interaction with our DNA. Again, this is something that happens in our bodies already, that mRNA is utilized, is part of our the things that our body does. And so there's nothing to suggest that there is no embedding into the DNA. It's clearly totally separate, doesn't go into the nucleus, nothing whatsoever to be interacting or affecting our DNA. And as I say, this is not anything new. Because this has been a long studied technology for over 2 decades looking at mRNA. So one of the questions we often get asked is, what will be the effect of this? Well, what we've seen in the clinical trials, and we haven't had the opportunity to evaluate the well over 120,000 people that have been vaccinated in Ontario for their first dose, and it's approximately, I think it's about 7,000 right now. It might be a little bit higher than that have received their second dose already in Ontario. We haven't had the opportunity to be able to follow and see what is their responses because it's a bit soon. But in the clinical trials, there was at least 50% in the Pfizer one, at least 50% within about 7 to 10 days of the first dose had shown an immune response that was ready to go after the virus. And similarly, after the second dose, it was even higher, to the point of 95% showed they did not get infection. So what they did is they had the placebo, so the non-vaccinated and the vaccinated. The 95% of the time the vaccinated did not get infections and also did show evidence of immune response. The challenge is we don't know yet, because still we're learning about this, as to whether it reduces your severity of infection. So then can you still have the COVID and still transmit that? That's what we don't know. We're going to learn about that. And we have a whole group looking at that, both in Ontario, but also across Canada and then internationally, to try to have a better understanding of that. And hopefully we'll know that fairly soon, given the multiple people that are being vaccinated and being followed closely. So we still do require, and people still will, are required to follow the same public health guidance, masking and distancing, after the vaccination, and 2 vaccinations as well, where you would then be immunized after 2. So we move to the next slide. So what about vaccine safety? Well, I've talked about this. Any adverse effects, we have a robust system that any effects, the people who are vaccinated are provided a information package that tells them who to call, when to call, and what to watch for if they have any troubles. And those then get reported to the public health units in Ontario. And each of the units have expertise and have experience in investigating vaccine reactions. It's the same, or side effects. It's the same as other vaccines. And they are legally then required to report that to Health Canada. And they have a very national approach to evaluating this. And both manufacturers for those the clinical trial folks are continuing to follow for at least 2 years to have a better understanding if there's any challenges. In Ontario, of the numbers that we've had, I believe, 1 reaction, maybe 2. It was a small number. It might be 2. I think 1 is still being investigated, where there were allergic-like reactions after. It was not anaphylaxis, and they both were managed, as I understand, with medical care that did not require hospitalization, from everything that I understand. There may be more, but those are the ones that I'm aware of. So nothing significant. We've certainly seen side effects, which I'll talk about on the next slide. And when you look at the side effects, they are common. In about, just going to look at my notes quickly. In the Moderna, it's about 1 in 10 will suffer pain at the injection site, maybe increased lymph glands, fatigue, headache, muscle aches and stiffness, and some have had some chills, nausea, and vomiting, although we have not heard significant debilitation with these. In Pfizer, again, similar to have the same number of side effects, about 1 in 10, and same types of symptoms. Again, in the first dose, we have not seen or heard significant challenges. We have heard that in the second dose, that the side effects are a little bit more pronounced, which is good. And why is it good? It's not good for the moment when you're feeling it, but it means that the body's getting going and reacting and doing the effective work of building up a process of response and immunologic response. So if you have side effects, there's nothing that is required to not do there's no reason not to proceed with the second dose. It is certainly important that, and you may have heard some discussion in the media about, well, the first dose gives this protection, we should use all the first doses up and not hold back second doses. And early on in the first week, till we knew our supply was going to be delivered on a regular basis, we did hold back the first dose. The second dose, so that we knew it was available to give the person their second dose. But now that we have regular supply, we're using as much as we can to make sure that as many people get vaccinated as quickly as they can do. And the reality right now, Doris talked about 24/7 clinics. We actually don't need them right now because we don't have enough supply. Once we have supply, then we're going to look at much broader, much faster, much bigger delivery pathways and maybe extending in broad number of hours such as that. But right now, really, we're pushing through in a much more effective way as we stood up all the clinics fairly quickly. So move on to the next slide. So this just touches a little bit on the 2 vaccines that are currently approved. The next vaccine that may be approved in Ontario is AstraZeneca, and that has been approved in England. Health Canada has not approved it. I'm not sure that everything's been submitted, but that is another vaccine, which is different than these 2. These 2 are both mRNA, and you can see that the age indication is 16 plus in Pfizer. There has been some discussion about potentially going between 12 and 16 in that group. That's still a topic of discussion, but clearly everything right now is over 16. So we have well over 2 million kids in school. And so we need to think about, is there other ways? Are they looking for other clinical trials, and thinks about all of these different things in figuring out when school age might be engaged as well in vaccination. But right now, as I say, 16 plus for Pfizer, 18 plus in Moderna, and then no upper age limit. The scheduling is between Pfizer, it's 21 days between the 2 doses. In Moderna, it's 28 days between the 2 doses. And you can see here that there was significant participants in clinical trials, with 95% in Pfizer and then 94% in Moderna. So significant efficacy from those 2, again, after the 2 doses. And now, if you think about it, we're over 120,000 in Ontario with the two different vaccines, each being provided uniquely, but the 2 together, and it'll also provide us significant information if to learn more about these vaccines as greater numbers are provided the vaccine. Next slide, please. So I think I've talked a lot about this, but it gives you a little bit of a view of what happened. So when we first received vaccine, we stepped up and recognized that Pfizer required ultra low temperature, -80. Well, there weren't that many freezers around. There were, but they weren't around all over the place as regular as you want, but they certainly were in hospitals. So as we stood up and got going fairly quickly, we did go to hospital sites. We did Ottawa and University Health Network in Toronto initially. They delivered the playbook, and they did all of the work with the first 3,000 doses in each, and then we've stood up to 19 sites since. It was hospital-based initially. That was, they needed to work and get their clinics going. But the reason, as I say, was because of the fact that it wasn't transportable at that particular time. Pfizer had said, you have to stay in the freezer, you have to use it very quickly, you cannot move with it. And part of the reason was whether it was stable enough, with transport, or did the bouncing actually make the vaccine not affect, does it cause it to be damaged and not be able to be suitably effective? So all of that was our initial steps, and that led to logistics impacting the work that we did, because our priorities, which I'll talk about in a little bit more detail in a minute, were those in long-term care homes and the staff, essential caregivers, residents, as well as other congregate living settings for seniors, because that's the highest risk of most severe illness, the highest risk of death, and the settings where we've seen transmission because of their congregate living ways. So early on, what we did is we targeted and asked for the workers from those settings to come to the hospitals because they were mobile as opposed to the residents being mobile. That was difficult, and so for many, and certainly hard. And we also started with a lower percentage of staff per shift, so that if people had side effects, they weren't limiting staff availability in the next couple of days after. And so all of that started things as quickly as we could. And at the same time, hospital or healthcare workers were also within the first priority to protect them from potential exposure to COVID, but also to ensure that we provide the best protection for the healthcare system to ensure that it's available for those who do get sick. So those two priorities were brought together. And early on, there was a priority matrix that was provided to the hospitals that they would look for the highest risk and step through. I can't speak to each individual hospital and how they applied that priority matrix, but what we know is that there needed to be people available to use all of those vaccines as quickly as they were available, because they don't have fridge life for a long period of time. So it was really to make sure that those doses were provided as quickly as they could be within those priority settings. I don't think I'll spend a lot more time on this, except for moving to Moderna. We had fewer doses in the end of December. We had 53,000 that were delivered. Those all went directly to be delivered into long-term care homes. So it's mobile, it's movable. So teams were pulled together in Peel, York, Toronto, and Windsor, Essex, because they were the highest case rates per thousand. And so those were the settings that were delivered. Teams were brought together, nursing in the long-term care home, nursing from outside the long-term care home, physicians assistants, paramedics, all mobilized, working with the public health units in the hospitals to go in teams if required, or to manage within the particular settings. And the goal was, and we're well on track for this, to have all of the long-term care homes, staff, essential caregivers, and residents offered and hopefully provided vaccine by December 21st. And so that we are ahead of that as far as I understand. I don't have the exact numbers today because I was so nervous. I was preparing for this presentation all day, of course, as Doris knows. I don't have all of the numbers, but we're well on track to doing that. And then we have additional Moderna coming, and we can now move Pfizer. As of last Wednesday, we had a whole series of pharmacists look at this very carefully and think about, can it be moved? And we are moving Pfizer to take it into long-term care homes as well in different parts of the province where Pfizer has been delivered to hospitals. And so we're focusing, again, keeping our focus on long-term care homes, high-risk retirement homes, and doing the whole setting. So residents, staff, essential caregivers, because clearly it's important to cover the whole setting as best as possible. So that's what's happening, and Moderna is going on. Did somebody? Yeah, so that's what's going on with the Moderna. So we'll move on to the next slide.
I just wanted to clarify, Dr. Huyer, the date for that completion. I think you said you might have meant January 21st.
What did I say?
December.
Oh,
I just want to clarify.
Yeah, we did really fast then. We did it before we had the vaccine. Yeah, January 21st is the first dose. First dose. Thank you for that very much. And yeah, first dose will be completed by January 21st. And then obviously Moderna is 4 weeks later. So by February 21st, all the homes in those 4 areas will have had vaccination. And then we're moving to have the rest of the province moving into the long-term care homes across the rest of the province as soon as possible. During the last couple of weeks of January and February. And so that is the priority still that remain. If there are additional vaccines, then I'll talk a little bit more about the prioritization in just a minute. Some of the questions were brought forward, and I think some are addressed in here. People who should not have the vaccine is if there's been a severe reaction to a previous dose. It's my understanding eggs are not an issue, but certainly something to talk about with the provider. Egg allergy is not an issue, but PEG is, and polyethylene glycol, and that's where we have seen some reactions, I think, in the literature and what we understand. So if there has been a severe reaction, that is something that's contraindicated at this point. I think as time goes on, there will be support within special clinics to be able to manage and support that with allergy-led support. Should be deferred in people who are thought to have COVID because you can't necessarily differentiate between COVID and the reaction from a vaccine. And so it's important to be able to differentiate those two things to see if it's a side effect. And what the information is that you wait till the symptoms are complete and you wait till you complete your isolation, as would be part of the process. And because we don't know for sure that you can't get COVID again, although there aren't a lot of cases of that, we are also vaccinating those who have had COVID before. So there is continuing vaccination of those. So when people come to the clinics, clearly you need to follow all the public health measures with lineups, separated, masking, and all proper things. And if there's been a previous vaccine within 2 weeks, then there shouldn't be done because both would intersect in a different way. And under age 18 or under age 16 are not recommended. Now, initially, what happened initially with the stepping up of clinics, which essentially was vaccinators, and they weren't they weren't the primary care physician or the healthcare provider that was intersecting with that particular patient. So they didn't know the patient well. Early on, areas that were not included in clinical trials, which was breastfeeding and pregnancy, and allergies were a separate thing, autoimmune conditions or immune compromised, those areas were excluded early on. And that was early because we needed to make sure that those areas that were not in clinical trials and there wasn't the ability to have the healthcare provider for that individual available, those were initially excluded. But what we've done is there's now special recommendations that are provided. We've rolled those out. They're available. So each of these areas, with consultation with your healthcare provider and discussion, weighing out the risks and benefits, they certainly are all now included as potential recipients of vaccination. Again, it's important that the risks and benefits are weighed through with your healthcare provider in pregnancy. Breastfeeding, there's nothing to suggest because it's an mRNA. It's not a live virus that it would transmit to the baby in any way. Pregnancy, the Society of Obstetrics and Gynecologists of Canada have made statements. Same thing with the immunocompromised. Statements have been provided. And so we're working on the best available clinical and medical advice, and we will adjust as we move forward. So absolutely, those are all included within the potential for vaccination. Next slide. So I just wanted to highlight that guiding the approach to prioritization. And when we say prioritization, the challenge is there's not enough vaccine and there's more people that want it and there's risk for some people. And when we look at it, the goal of vaccination is to reduce overall illness and deaths within COVID. But at the same time, we also want to make sure that we protect critical infrastructure and we promote social and economic well-being. So there are multiple things that we're thinking about when we work through how do we think about who's vaccinated, when they're vaccinated, and what's the approach to that. So the approach is important because that's logistics, and we talked about the challenges we had with Pfizer. The who, we're going to talk a little bit more in just a minute as far as the healthcare workers go, but we talked about the highest risk, which are the long-term care and older adults that are in congregate care settings. And so thinking about this, we wanted to make sure that we have ethical principles that guide the sequencing of populations and groups that are to be vaccinated. And these are the 5. I'm not going to read through each of these, but there are 5 core principles, and underlying all of those, there's public trust that is that allies everything. So letting people know exactly how we're doing things, what occurs, And I know some of the questions have asked some questions about who got prioritized, how did they get prioritized. We're laying out what frameworks have been provided, then decisions are made. Provincially, we lay out those frameworks, we let people know, and then people are informed and provide feedback. And then because of local unique factors, whether it be at the public health unit, whether it be at the hospital, whether it be in the primary care practice, whether it be in the long-term care home, we can't be able to drill down into all of those unique practices and decisions that get made in all of those different levels. And people need to make their decisions based upon the frameworks that are been provided to them. But we feel strongly the ethical framework is fundamental to all the decisions that get made. And again, if we had more vaccines and we had lots of vaccines, everything would be happening in a much more compressed time. And that's our hope as the spring moves forward, that we have many, many more vaccines and that everybody will be offered that opportunity much more quickly. Next slide. So these are the populations that have been sequenced to receive vaccination initially. And I've talked about it already. It's the initial box, as you can see, is the residents, staff, essential caregivers, and other employees of congregate care living settings. And then we're going to talk a little bit more about healthcare workers, and that includes hospital employees, but it also includes those who work or study in hospitals and other healthcare personnel that are broadly within the healthcare field, and even includes people who would be providing healthcare services that may not be a healthcare professional. So example, in a shelter, there's nursing staff, there's physician staff, but there's peer support. And those peer support would be providing significant, valuable care. And so it'd be similar to the care to the person in the shelter. So that it considers all of those options. There is a document that's available, and that was released late Friday, that allows the framing of this and thinking through it. And the third category are First Nations, Métis, and Inuit adults in Ontario, and those are who across remote fly-in communities, but also other First Nations communities, and including urban Indigenous populations. And then finally, adult recipients of chronic home care. This again is a population that's of higher risk and are regularly receiving health care. So they are also in the first grouping. So this is the first grouping that was chosen. There are people who would dispute that this is the right way to go. It is the decision that's been made based upon highest risk populations, number of vaccines, and the availability of those vaccines. We are soon going to release phase 2 populations. They're in discussion, and they're soon going to be released, I think within days, although I don't know that for sure. And those would, again, align with the greatest risk. So thinking about potential ones would be adults above 80. So why not adults above 80 here? Well, it is a high risk area, but we're thinking about who is the highest risk. And so those over 80 definitely are at risk of serious illness, definitely at risk of mortality. But if they're not living in a congregate setting, have the ability to protect themselves a little bit differently than those do who have the living in a congregate care setting. So absolutely important. So older population. We talked about infrastructure. So essential workers would likely be within the next category. There's others who are living in congregate care settings that clearly have vulnerability, shelters, developmental services, other settings where people have high needs, medical, psychological, and other needs. Those would also fit within the congregate care people who are at risk of serious illness. So they would likely be in the category. And we also know from what we've observed during COVID, but also is known across health equity discussions, that there are certain populations and communities, and those populations are racialized populations, including Black, and also in communities where there are other determinants of health driven reasons why they would be at greater risk. So they would likely be another priority population that will be looked at. And then there are people who have chronic health conditions that are also at greater risk. So, for example, dialysis, where do they fit together and how do they come in? So again, all of these sound like high risk, and all of these sound very significant. And the reality is, again, we need to prioritize based upon risk in the best way possible. Next slide. So what about healthcare workers? Well, we've talked about who they are and what we've done as they fit within phase one. There clearly are different risks within the healthcare setting. If you have direct patient care, if you're involved with aerosolized generating procedures, if you're working with those who have chronic conditions, clearly all of those things are examples that add the risk to you, but there's also the risk that you, not you, but a healthcare provider brings into that population. So the healthcare provider that enters into the long-term care home, again, brings a risk into a population that can have significant challenges if they get sick. So those two things are really important things to think about. So what we've done is we've taken Public Health Ontario data, and recognizing that COVID time is fast time, so you don't have as much time to think and prepare and plan and consult, unfortunately, where the Public Health Ontario has data-driven approaches to risk exposure for the different occupations. So we've taken those and put them into different priority groups. And then we brought that to a subgroup of the vaccine prioritization subgroup, which reports under a clinical work stream. And it's a group of 16 physicians, also bioethicists, microbiologists who have expertise in different parts of prioritization, of understanding the health system. And Doris pointed out once before that there is not a registered nurse on that, or a registered practical nurse, and that was good feedback. That'll change a little bit more as we move into the healthcare worker broader prioritization. And I appreciated that feedback, Doris. Thank you for that. Sorry that I didn't do that. Again, always learning. And
or a nurse practitioner.
Exactly. Yeah. And or a nursing student. But we did have, and what they did is we took a plan to them, and they thought through this from a health equity lens, and provided their specific thoughts about this. And we also talked with operational partners, and then had some input from a variety of settings, multiple different SAs that provide healthcare. So I've defined in the box what healthcare are. It's very broad. So I saw a number of things coming up in the chat. Private contracted nurses would be fitting in. Nursing students would fit in. RPN students, paramedics fit in. And they would all be examples of healthcare providers. And I could go on and on and on, but healthcare is a fairly broad concept for this. Next slide. So after we take that first broader categories, where we put them into categories of exposure risk, and then we put them into dealing with general population or specific population. So the specific would be like the long-term care homes. The general would be working across province. So a primary care practice, for example, see a whole range of patients. Some of those primary care patients practices would those specifically focus on specific populations. And so those would then be prioritized above other primary care practices. And so the first thing is you get the broad setting. The second sector is that the public health units will look at the risk within their community. So there might be different community risk factors. There might be different health care challenges that may be present. And then you come down into the individual workers, where if you have worker A that's doing the same job as worker B, the older of the two goes first. And of the two, there may also be other factors. They may come from a racialized community. They may have individual biologic factors that would put them at greater risk. And so that, again, is used in the prioritization at the individual level. Next slide. So this I've talked about, but the way that the Public Health Ontario exposure works with, and also it also, the other way to prioritize is to think about the risk of severe disease and then the criticality. So different subspecialty or limited availability of that particular service provider may enhance the criticality. And I use the example, and not anything, but it's fairly straight example of a respiratory therapist in the ICU. So the respiratory therapists, there aren't a lot of them. They have a particular skill set. They're in an area of significant risk to illness to themselves and also a risk to illness to others. So that's an example of a healthcare worker. Not saying that they take over everything, but just an example of the criticality and many of the things in the chat box would certainly fit with that as well. So step one is to get the broad settings and sectors. And then step two, we'll go on to the next slide, which is the public health units. We'll then prioritize. Now, all of the questions you said is when are we, all good questions. And I wish I had those answers. If you go to New York, you can see they've set it up in week by week by week. That's because they know their supply. We don't know our vaccine supply, which makes it very challenging for us to schedule people. And it also makes it very challenging, given the diversity of the group and the questions that you've asked, for us to have a simple pathway to be able to do it. So this week, what we did is we developed this document. This week, we're working together with the public health units to try to help them to get a systematic approach. They're going to do this, but we want to see and help them to figure out how to develop their committees, their groups, how to work with the RNAO, for example, the OMA, the OHA, and others to be able to have a way to get a delivery mechanism. So that work still needs to happen. So I don't have answers to when. What I can tell you is it's not going to be this week, and it won't be next week. And it probably won't be the week after, because we are focusing so much on the long-term care homes right now, and the vaccine supply is not substantial. But we need to work on this, but it's coming, and it's coming, and it's fairly soon. So that's the way to think through this. So this is what happens when we get down into the communities of greater risk. And I've talked about this pretty well already. Again, this is data-driven to the extent that we can. The Public Health Ontario has sent out information to individual public health units that shows some prioritization and some risk factors that are present within each of those communities to be able to help to inform these discussions. And I think you know about the challenges that occur. And this is what I talked, sorry, go ahead, yep. And this is the next one is what I talked about individually. So individually, clearly priority goes to those who are providing direct care and not to those that are providing virtual care. And I think in the chat, there was some comment about people who didn't have didn't frontline care. I acknowledge that. Again, I'm not going to speak to the complexities that led to that decision. I'm sure there were complex decisions about making sure that all vaccine was utilized and providing to someone in the healthcare field. Again, I won't comment any further because I don't know the specifics of individual situations. But the point is that they do need to have frequent or sustained care and away from and being inpatient care situation. And then specifically, greater than 60 is recognized as an age that is higher risk to infection and serious outcome. And then there's the other biologic, social, or geographic factors that are also important. If you happen to get down, and we happen to have enough people where there is an equal between the two, then a random number generator so that it's fair between the two. So very high level to very granular, and then kind of gray in between on how that exactly is all going to happen. Next slide. So this is a decision tree. So for example, if you go into question 1, it says, did they meet the healthcare worker definition? And as I said, if you look at the document later, you'll see it's those who are regulated healthcare providers, but those who are recognized and are providing healthcare services as well. And in situations where they would be providing a healthcare service, not necessarily as a healthcare provider. So a social worker in a shelter, a peer support within a shelter may fit within that. So if it's a yes, are you in a sector or setting that's in a high priority community? Yes, then you would proceed in the higher priority process. And then do they have direct care? Yes. Then are they over 60? Yes. Then so it just flows you down the pathway from the broad sector or setting situation to be able to roll down into the individual worker. Next, and there's some examples in the document as well. This is an example of what was provided in the hospitals, which I've talked about. So I'm not going to go into detail, except to illustrate that if you look at the risk matrix, at the top, it's 2 criteria, not one over the other. They're both equal. The risk of getting exposed but also the risk of transmitting to a special population. Both those need to be considered. And then you also need to think about the criticality. So this illustrates if you take the respiratory therapist in this particular situation, they're at a high risk of exposure because of the aerosolizing generating procedure. And they're also at a moderate to high risk of because they're close involvement, people who are sick, who require respiratory care, a greater risk of suffering serious consequences. So they would be likely in the moderate to high. So they'd get a 4 or 5 score. And then criticality, probably doctors and nurses and others can provide much of the RT care, but not all of it. So criticality, probably about a moderate, existing capacity, about a moderate, essentiality of the critical system, high. So they get about a 1. So that would be 5 or 6 out of 7. So they would be prioritized fairly high utilizing this. Now, this is a lot of work, but this is what we provided to the hospitals to think through on how to do this. Next slide. And let's talk a little bit. This is as of yesterday afternoon. So 116,000. We're now well over 125,000. Again, I don't know the exact number. I suspect by the end of day today, we'll be well over 130,000. What we did with long-term care home is that we went in fast without the IT system all finally fixed up. We've used the IT system in all hospitals. It collects a systematic set of data. We're doing it centralized. So in the long-term care homes, we didn't want to wait. We went in with paper. And so that paper material is going to be added into the records as quickly as we can. And then we'll have a full understanding and continue to do this from a provincial point of view, not at local EMRs or that way. We really want to have a good understanding to be able to understand what's happening across the province. Next slide. I think actually I'm going to stop. This is some numbers. I've talked about a lot of this. I'm not going to go through these. I want to talk about the questions that were sent to me early, and then we'll move on to the other questions if that works, Doris. Is that good? Okay, I saw a perfect.
It's perfect, yeah.
So some very granular questions, some high level questions. One of them was asking about gloves. Should gloves be worn? And the answer is best practice, but it's not mandatory is the understanding that I have. Best practice because there might be bleeding after with the vaccination in some people, so there could be potential transmission of illness. And then also some protection from a needle poke. Not necessarily is there complete protection, obviously, because it can poke through a glove as well. But that's the gloves. There were a number of questions about when will people get and what is the plan. I'm not going to dwell into that because I don't have the answers any better than I've given, that we are still working through all of those. But nurses who are self-employed, yes. All our healthcare workers, nurses in urgent care walk-in clinics prioritized. The answers fit within the matrix as it does. And I'm just looking through quickly. In high-risk communities, when we will not be only hospitals. We've pivoted from hospitals being the only site as of this week. And so now that Pfizer is being taken out through strict protocols so that we ensure that we do the best protection of the vaccine and provide that. So that's moving, but we've moved into the long-term care homes and the high-risk retirement homes. That's where we're going first. We're delivering to all of those settings first. And that's the direction that we're going. Can you help with the vaccine? The answer is yes, but right now we aren't struggling substantially with vaccinators. We will be, and we're reaching out to primary care practices. We're reaching out to others. The allocation folks are working hard on that to develop a plan to be ready when we get 1 million doses. So we'll have teams going out. We'll have primary care practices delivering. We'll have pharmacists delivering. We'll have mass vaccination clinics. All different ways, and different people will go different places. So the communities at risk will deliver. We'll go into those, work through with the communities, figure out what is the most effective way to deliver. The shelters will deliver. Mass vaccination clinics will be the general population. The primary care doctors and pharmacists, those over 80, those over 75, as they have their weeks to go. That would be the likely way that we anticipate it happening. And so there will be different work that can be occurring during that period of time. Looking a little bit further about vaccine confidence, I like to use the word vaccine confidence. A lot of people describe it as vaccine hesitancy. There is a lot of work that's happening, but it's challenging. There's no question it's challenging. Hopefully today is going to help with vaccine confidence in some way, or at least answer questions, allow people to think about this in greater detail. So there is a lot of work that's occurring from a communications perspective. There has been interviews of folks who are in certain communities, people who are in certain practice areas to try to help to develop targeted education, have leaders within different fields. You're all leaders. Each one of the 806 participants is a leader here. You can lead with your families. You can lead with your communities. You can lead with your colleagues and thinking through about this. Explore, learn, think about things. Very, very important to have a good understanding. So yes, there is a lot going on. Could there be more? Absolutely. And do we hear it every single day? I hear it about 10 times a day. Do more, and we're trying. When Doris provided this opportunity, I just jumped at it. And it just is just an opportunity for me to learn, but also for me to share and for you to learn as much as we can.
And we will do again in February, Dirk. It's open to all health professionals, by the way. I sent to all the associations. So there is many other professions today here. And just so you can get a bit excited or nervous, whatever, we did surpass 800. So you are keeping them all interested and more coming.
Well, I'm doing my best, Doris, doing my best. Then there's vaccine safety. There is, if you go on to the COVID-19 Ontario website, there is a vaccine specific area. There are a number of documents that are written from a patient perspective, but also a healthcare provider perspective. Take a look. We're trying to make sure that we provide consistent messaging from a provincial level to allow people to gain understanding. Clearly, there's lots more that's going on. We're also working as effectively as we can, which is to work with different associations, with different, to amalgam all the different groups that are leading these education, trying to contribute together with everybody so that we all say the same kinds of message. Not to be saying the same message, but to be speaking and thinking together about what is the most effective way to be able to provide information to others. I think I've talked about the pregnant. Yes, I have. And vaccine cause reactions or death. Well, that is my other world. We have not had any deaths that we're aware of in Ontario related. There have been 2 literature reports, as I understand, newspaper reports. One was a person who suddenly passed 2 weeks after receiving the vaccine. To be frank, and I'm not trying to, this is not anything but my death world. It sounded like a sudden cardiac event based upon what I read in the media. What we would do is, if that happened in Ontario, we would be exploring that in great depth and great understanding to fully, transparently figure out whether there was any relationship whatsoever. But what I can tell you, over 130,000 people, and if somebody had died, I'd know about it. That would be a call to me in my role as a chief coroner. So knock on wood, I have not heard that. Could it happen? I guess it could. I hope that it never, ever, ever does. We have had some reactions, but it's, again, I talked about them earlier. There's only 2 that I'm aware that were significant, and those were significant to get medical care, but they were not requiring overnight stay or anything significant. And the question is, do we need to stay 15 minutes after? Yes, we do keep patients 15 minutes after for the potential for anaphylaxis. Very, very important to ensure that. And if there's allergies, working directly with your primary care physician, letting people know, then there may be an extended period of time to watch after that.
If I can, Dirk, because already 5 people have posted this question. I know it's not a pleasant one for you, but it has been all over the media today. And likely you will not be able to answer. So after you answer, I will answer too. It was sent several times. Can we get an answer to the question regarding the queue getting out of the queue? For example, the news that at UHN researchers are being vaccinated prior to frontline. And I think the reason it's important that we answer these questions is because it erodes confidence unnecessarily. So if I give it to you, and then I also want to make a comment on that.
Yeah, I can't speak specifically to the University Health Network, but what I can tell you is that researchers would likely fall within the healthcare work potentially. I can't say I'd have to see the specific, but they would potentially fall within. And what happened was that we prioritized for those who are long-term care staff to attend at the hospitals when the vaccine was hospital-based, because early on we were not able to move that. What we didn't want to do is have a situation where the vaccine was not utilized as quickly and as promptly as possible. The healthcare field generally, and this isn't any explanation except generally, we're trying to do programmatic work, right? So programmatic means cover off a whole sector. So cover the whole long-term care home, cover everybody that works within that hospital so that there isn't that infection that comes in or is brought in. But what happened was that there wasn't the ability to fill all of those vaccination spots. And so the hospitals likely, I don't know for sure, likely provided those spots to people who were immediately available when somebody didn't show or when there were people that were not lining up. And we have to make decisions very quickly. And it was not, logistics drove how this first part started, because it drove us to the hospitals, and that meant that everything wasn't necessarily as open. Not open's the wrong term. There wasn't the ability to provide it broadly out into the community, which is what we're doing now. So what we're doing now is we're going out to the long-term care homes. There was certainly a desire to have vaccinations done as quickly as possible. And so there may have been some that in retrospect may not have been provided that opportunity had there been the ability to be disseminating or sharing that vaccine otherwise. But I can't speak specifically.
So I will comment in a very transparent way, because I'm familiar with several of the individuals. I have spoken with several. I think that to augment what you said, which is absolutely the case, I want to say that no system is perfect. No system is perfect. And the same as we have had situations of people going abroad when they shouldn't, you will have situations, and I don't want to skirt from it because they will be likely in the media, where you will have people that jump the queue. No system is perfect. It's the reality. It's the reality. Where I take more issue is with the issue that Pfizer could not have been going to long-term care before, because this same government is using Israel as the example every other day. And in Israel, actually, Pfizer went to the long-term cares first, to the malls, and they set it up outside of hospitals. So we knew this country was slow in actually moving with Pfizer to long-term care. And on that, aeronautics issue, in the sense that, yes, of course, ICUs, of course, staff that works in ICUs, emergency rooms, any unit where you have a large percentage of COVID, patients with COVID, no doubt hospitals were at risk and their staff too. But long-term care residents, their staff and their essential care partners were dying, and they continue to be dying. So I would suggest that one vaccine in the fridge is too many. 24/7, whenever we can, we should do, even if we have one shipment, let's go give them right away 24/7 instead of lengthening the time to 3 days instead of 24/7, because it saves lives. It does save lives. And that's the biggest anti to the vaccine hesitancy is, please, let's be real, it saves lives. So let's put them in the arms of residents, their essential care partners and their staff ASAP. That's where people are dying for the most.
Yeah, thank you, Doris, for those comments.
So,
now, Susan, you want to take the questions?
Yes, you've done a marvelous job at answering many of the questions. A lot of them had to do with the rollout. And I'll just start with sort of grouping a theme here around the rollout. So people are asking sort of how will they learn when it's their time? What will the rollout be for maybe phase 2? Will that be alphabetical or year? And then what about, and I can repeat, but what about grocery store workers and people, teachers and custodians in schools? Would you be able to answer those questions?
Yeah, so we don't know right now exactly how the process will flow for the rest of the healthcare workers. That's stuff that's planning that needs to occur over the next week or two. So we wanted to get the prioritization process in place, and now that needs to be translated into implementation. And I wish I had an answer for you, but we don't have vaccines beyond what Doris was talking about for the high risk folks, and so now that prioritization will take some time to get implemented, but it is within the period of time, anticipated to be within the period of time before March and before the end of March for healthcare workers. That's the way we've planned it, but there will be sequencing throughout, and that work is being done and will be led by the public health units. So there's no straightforward answer I can give you for that. As far as the phase 2, which is after March, those areas, the populations have not been determined or announced publicly at this point. And so that will be known hopefully within a number of days, because things like what we've seen in other jurisdictions and seen from the National Advisory Committee on Immunization have suggested people above 80 essential workers to make sure that the essential infrastructure stays in place. So those are the things that I anticipate will likely be in the post-March period. And again, at that point, we're hopeful that there will be lots of vaccine, and then it will be a matter of weeks as opposed to a matter of months. So this period of time right now is anxiety provoking, is challenging, and is something we would very much like to get in there. I just see right now nurses working in child welfare, and yes, nurses are healthcare providers. They would be, again, in that situation.
Great, thank you very much. So I'm sure there will be lots of detailed questions about that, but you've done a beautiful job at summarizing the main points. Questions are around the duration of coverage of the vaccine, and also about people who might have had COVID and carriers. You spoke a little bit about this, but or if they get COVID between vaccine number 1 and 2. Can you speak to some of those issues?
Yeah, really good questions. And the answer is we don't know yet. So there's a particular surveillance subgroup that's also working on the work stream that I'm leading. And we have a vaccine expert, vaccine safety expert, Sarah Wilson from the Public Health Agency, Public Health Ontario, and also a number of local medical officers as well as scientists that are on that group. And she's also working with the National Advisory Committee on Immunization and the Public Health Agency of Canada. So having said all that, questions that we're going to ask are vaccine uptake, vaccine effectiveness, vaccine efficacy, and length of that. We don't know the answers to those questions yet, but we know that in the Pfizer, it was many days. I think I have to look, but I think 80 to 90 days out past vaccine, there was still evidence. I'd have to double check that, so don't quote me on that one. But it was certainly well beyond 50 days that there was evidence of continued immunity based upon evaluation of a small number of people looking for antibodies. And so we do know that. But again, what we're going to see and we're going to have to figure out over time is really understanding how effective it is. Does it protect from infection? So, sometimes with influenza, you might still get influenza, but you'll get it less severe. So we need to know, is that the situation? Because other vaccines like measles, you don't get measles if you've got fully immunized. So it's figuring out that, and that'll help to inform, do we need to keep doing testing of people, say in long-term care homes where there's testing every week or every 2 weeks? Thinking about knowing whether that needs to continue. Do we need to keep masking? Do we need to keep wearing our distance and all those sorts of things? Those are the answers we don't have yet. And so at this point, we're being very careful. And then how long does it last? Do you need a booster in a year? Again, we don't know. What I can say is evaluation of the variants. So the UK variant and the South African variant, that's been looked at by the vaccine experts. And and the answer has been that it would be protective for those as well. So that,
and I believe the one from South Africa too, I believe.
Yeah. So yeah, absolutely. So that's the answer. It's not really an answer. It's a non-answer, but it's an answer. So it's what we don't know, but we're looking at it.
Thank you so much. So I'm going to give you a little pause and put a question to Doris so you can catch a breath and get a drink of water. And Doris, there are lots of questions about people eager to participate in providing vaccinations. And can you to that
So
for a
I
moment?
did, yeah, absolutely. So two things, first of all. One is that there is already an army of workers, and I spoke with Dirk last week about the numbers, and I tweeted about that just a few minutes ago too, in primary care and in public health and in home care that are ready to work and are already on the payroll. That's number one. And they have not been put to use because of the quantity of vaccines that we have. Although I will frown if the same answer I get later on when we have a lot of vaccines, because as I said, RNO believes we should move 24/7, and not just 24/7, quite frankly, in nursing homes, 24/7 everywhere. And let's get over with this virus in, June instead of in September. There is no reason, and that's what other countries that are successful are doing. But for those of you that do want to register, we did set up in our own careers, and we will be able to give you access to that and to your team, Dirk, if the need will be there, of nurses that want to come off the retirement or that work part-time or that work in schools as faculty and want to volunteer. Absolutely, we are collecting that data. We set it up last week, and there were a few hundreds already in a matter of a day. So please go to our career, Susan. Maybe you can put the link. I can put it again after. I also will take a chance to tell you that I just noticed another link this is very big actually, and we will send an action alert on this. The Toronto Star just put a petition to fix the mess in long-term care, not related to vaccines, but everything that RNO has been asking. The Toronto Star also in the weekend published our basic care guarantee. They're now asking people to sign a petition. We will be sending it to people today so that we have, I don't know, 1 million signatures of people telling every single government and every single party, provincial and federally, get on with the show, not just for elections, but now with fixing long-term care. This is not just a COVID issue. But I will put their careers in a minute again. I had put it before, it's there. Here you go. So you guys can go to our careers, and there is a segment there that says, if you would like to participate in inoculating people, please put your information there. It's all there. Thank you.
I saw a quick comment from Allergy Canada, I believe is the name of the group, a very a great group that really takes on a challenging issue of food allergies as well as drug and other venom-related allergies. And so the ingredients are on the website, but the one that's reportedly, and I'm not going to read them all because there are multiple different ones, but the one that's reportedly been challenging is polyethylene glycol in both the vaccinations, but other ones are sodium acetate, sucrose, there's acetic acid, there's 2 different lipids in the 2 different ones, cholesterol, again, very small amounts of these, potassium chloride, sodium chloride, monobasic potassium phosphate. So there's a few others that I haven't gone through all of them, but they are on the website that are present. No, that is not, Jennifer, that is not included. I always forget how to pronounce that. Thermosol. It's not in the vaccine.
Great, thank you. A question I don't think you've answered yet, and then I'm going to see if Irma Jean has identified any questions to their priority and her opinion. Do you think people are going to need a note from, to come and get vaccinated? And also a link to that, do you think that there's going to be a digital immunization record?
All of those questions are still ones that we're working through. So what happens when a person gets their first vaccination is that they do get a receipt for that first vaccination. And we've been working through how to confirm immunization, which means 2 doses. They will all be maintained and held in the central database. So there will be that understanding. What is unclear is whether there will be a further provision of that. So don't know the answer. As far as getting vaccination, that is still being worked through. We really, each different setting, like clearly in the long-term care homes, you know who a resident is. Healthcare workers within the hospital, there was requirement for them to have their identification and to indicate where they came from. And so there were different, and there will be different setups on how things happen. If you're in the death investigation world, for example, as a coroner, a medical coroner, we'll ask them to show their badge and show their health card. Now, health card is not necessary for that. If you have a health card, though, there is the expectation that a health card would be provided, but it's not necessary for people who don't have health cards.
Okay, I'll move with a few questions now, and thank you. This is so informative. The first question I have is, if you've had other types of diseases like Bell's palsy, Guillain-Barré syndrome, herpes zoster, will this interfere with the vaccination? And is there an assessment done prior to the vaccination being administered?
Good question. A little bit outside my ability to answer. Those are all specific health conditions that may be present. And I think that would be something that it would be a conversation with the healthcare professional who you have a relationship with. When there are special circumstances, there should be a conversation, certainly now in the vaccination clinics, because they're not going to be your healthcare provider, and they may not be in a position to have detailed discussion. They will be evaluating for those for other health conditions. There is a full consent form process, but there may be a value and importance in having discussion specifically with your healthcare provider if there are conditions that may be thought of as potentially intersecting with it. So again, not a specific answer for all of those conditions. We do have specific advice on pregnancy, breastfeeding, immunocompromised, allergies, and those who are taking anticoagulants. So there is that already included on the website from a provincial point of view, and they're linked with different statements from those societies, those areas. So the Canadian Association of Rheumatologists have provided advice on the immunocompromised, and so there are different areas of advice.
Okay, thank you. And then I think I would know the answer to this, but would it ever be a situation where one receiving the vaccination would have a choice of which one they receive?
It's a good question, and right now there is the both of the mRNAs, and they are being provided from a logistics point of view, and there aren't two choices coming to that particular facility. So right now, with the delivery mechanism, we're trying to provide, again based upon logistics, trying to provide to all of those who work in the long-term care home at the time that the residents are being vaccinated, and that would be. There would not be bringing both Pfizer and Moderna. Both are similar in their makeups as far as everything that we know.
Mm-hmm. If one did have a choice, would you provide any consideration one should be aware of?
Premature to answer that question because, again, right now, that hasn't been something that we've contemplated. So I think it would really depend on the properties of the vaccine. And right now, these two are very similar in properties. It hasn't been a significant difference in either efficacy or the type of material. The primary difference is the properties of storage and movement right now.
Mm-hmm. And then I have two more questions. One is, and I think you may have implied an answer, how will the public know when they will be soon to be in the queue? Will it be radio, television, newspaper, or all of the above?
The public generally, there will be, it's posted on the website. Premier Ford regularly talks about the vaccine. General Huyer talks about the vaccine. There will be also public messaging responding to individual community, individual populations. So it may well be that if there's a decision, I'm not saying this would happen, if there was a decision to do over 80-year-olds during a certain period of time, then that would be released probably publicly. I don't know for sure. And then also family practice, primary care practices, those types of practices would then be able to use their EMRs to reach out to those who may be at an older age. So there would be a variety of different approaches that would likely be utilized.
And do you anticipate an individualized approach, like a telephone fan out or anything?
Unknown at this particular time. Those things that I've put forward is what we're believing to be potential ways to go. So we don't know that those aren't planned right now. Those are areas that have been explored.
Okay, and then the last question I have, and I'll turn it back to you, Susan, is you mentioned a receipt after you get the first dose and then you'd have the second dose. Would there be any more permanent card one might have that they could share with an employer or any place that might require them to be vaccinated prior to entry or working there?
Yeah, that's still a topic of conversation. So I don't have an answer for you at this point, but it's an ongoing conversation that's occurring. We wanted to get vaccination started and then have all of the data available, have the ability to provide that verification through the central provincial database. So having the answer to that question, we don't know yet.
Okay, thank you. And Susan, I'll turn it back to you if you have other questions.
Okay. Wow, we're just sending you so many questions, one after another. But this next one, I wondered if you had anything more you wanted to say about vulnerable populations, which is something that we talk about a lot at RNAO. A couple of questions in the chat box. We're wondering about inmates, homeless people. Did you have anything more that you wanted to say about prioritizing those populations?
So the initial prioritization is focused on the 4 areas, which we talked about earlier. And so the second phase is likely to be, I think, publicly announced and brought forward over the next few days to week. I don't know exactly when. Other jurisdictions have, again, just as we have looked at things from a risk perspective, it's recognized that other vulnerable settings are in congregate setting situations are at greater risk of illness and greater risk of serious consequences. So it makes sense looking at other jurisdictions that they would be logically soon in the next sequence to be vaccinated.
Great, thank you. So you spoke about vaccine confidence. I think you used that term. There are a couple of questions about myths and sort of bizarre claims about the vaccine. Do you have anything? I know Doris probably has some thoughts about this as well. But do you have any advice or suggestions for people who, are spouting myths or really concerned?
Well, I think it really flows from what is the basis of that myth? And one of the ones that I've heard is that there's a microchip put in with the vaccine. There's no evidence, and well, it just doesn't happen. It simply is not happening. But I understand how I've heard that. It isn't something that, anyways, it's not something that's doable from in a scientific way. I think it's important to understand the basis for the myth and understand what that is and why people would have that particular concern. I think really understanding, having knowledge. This is mRNA technology has been studied for over 20 years, and this has allowed us to make vaccines more quickly, and will hopefully continue to add in our strength towards using mRNA in other forms of healthcare. So very important to think about the fact that this is something that's been studied. There's 30,000 people that were in one study and 45, I think, in the other clinical trial. Health Canada carefully has evaluated and looked through these. This is safety from a Health Canada point of view. So it's not that we cut any corners, they did the corners faster. So they were able to build the clinical trial numbers faster than you would have in many vaccine situations because of the challenges of COVID and because of the ubiquitousness, how widespread the infection is. So we were able to do that testing very quickly in clinical trial. And since we've had over 130,000 now without any significant challenges. We have a national approach. We have multi-jurisdictional, multi-countries involved in these two vaccines. So there are many who have shown that there haven't been problems, and we would talk about the problems if there were. And we've talked about where we have a reporting process that does go public as well.
I would like to add comments to that. Thank you, to build on what Dirk said. I think it's very important to understand the nature of the concerns and who brings the concerns. It's a bit, and Dirk, you are very familiar with MAID, and also on MAID there were polarization. I think here what has happened in the US with President Trump, to be quite frankly, has had a significant and devastating impact, and so is what's happening in Brazil with President Bolsonaro. And one cannot separate those aspects and the influence, the negative influence they have had. I think there are groups that have valid concerns. Those are groups, for example, from indigenous communities or from Black communities, where experiments in their past experience have happened. And it's very important that we listen to them attentively so we can, number one, listen and understand from where they're coming, and second, alleviate their concerns at this time, because they have valid reasons from past experience to be concerned. Second, is the group that are the same as the anti-vaxxers, anti-maskers, etc. And just to add to that, that I reported to nurses today that were in the media, so nothing is private about this. They were on the media yet again on the weekend. But those are people that propagate purposefully wrong information. They purposefully do that. There is a political purpose to it. And I think those are the people that we need to severely counter with others that have the evidence and know how to counter that. And the third is people that don't know enough. Today is the perfect example. I'm sure that many of you came with questions that needed to be alleviated, that you are thinking, well, I don't want to be the first. I can tell you, I want to be not just the first, I want to be ahead of the line so fast. I just cannot, because I don't work in any situation that I have a right to do that. So I would never do that, right? But if I were in an ICU, I would have been the first one saying, try me first, right? Remember, there have been multiple vaccines working together and combining and sharing expertise. There have been multiple countries working together. So I think that, and also remember, this is a virus that we had during SARS, just a different type this time, right? So there was all those years of work. It's not just now. All those years of work plus all these multi-site, multi-research, multi-patients, by the way, that are getting the vaccine now. So I can tell you, I feel very confident with the vaccine, any of them, quite frankly. Well, any of them that we have brought to this country. I have huge trust on Health Canada and their processes. What I do think, though, Dirk, is we need to rebuild the trust here in Ontario, not about the vaccine, but about the issue of long-term care should be first. Long-term care should be first. And also if you need power from us to help you, that when we get tons of shipments, that we go 24/7, so we get this over with. If anything, the moment we will have more and more people rolling up their sleeve. I know that my president, who I tip my hat, and I tweeted about that yesterday, because she changed from a very secure employment to become a director of care, Morgan offered, the director of care in a nursing home that was in an outbreak. Now that takes guts to move from a secure employment, no COVID, to something. She had a chance. They call her finally because they're vaccinating her home and the residents and stuff. And she's a lot in the units. And I was concerned she was a lot in the units and had not gotten the vaccine. Finally, yesterday, she got a call. And my gosh, I said to her, give it a tweet. And she tweeted, and I think Morgan has had the most retweets and likes that ever she will have in her life, because people are excited about this. I think you also counter the people that have hesitation for the wrong reasons, not the ones that for experience have had issues with their family or ancestors or whatever, right? That we owe them an answer, and we owe to embrace them in their concerns. And then the rest, trust me, the rest that are just putting just propaganda, quite frankly, some of them, you counter them with, here, I got my shot. That's it. You will never do away with all of that. You will never. We didn't do it away with the flu either, and people continue to die with the flu. People forget that here, a lot more easier, a lot more people die, that this is not just a flu.
And we are specifically working with communities that where there is trust, have been trust issues based upon solid history and based upon concerns, as Doris talked about. We specifically have started that work and hearing from communities, understanding where the gaps are and where the trust arose from, and then providing information and hearing and how to help to enhance the education and provide additional information co-developed with those from communities.
Yeah, and we are also building on that work. Just so you know, Dirk, we are working with the Toronto Public Health Unit specifically on that same issue. And what I propose to the Toronto Public Health Unit, and we will open it for everybody, is that when we do in February, and I was not joking that we will bring you back, just to give us a shorter update, we will bring Cora Constantinescu. I don't know if you have heard of her, Dirk, but she is, I could listen to her the whole time. Like people bring the most incredible questions that are not based on your past experience, but just to poke. And she never loses the calm on saying, good question. And she has a way to talk with people that really teaches a lot on how we should be talking with people that bring whatever concerns were valid or not valid, aside of the ones based on past experience, but concerns that are not necessarily based on evidence, shall I say.
Don't at the time, it's 3:33. I wonder if there's time for a couple more questions and then maybe work towards closing up the call, if that's okay.
Yes, and the only thing, Susan, to remind people and maybe put on the website, RNO COVID portal, and there is a site there, a link there specifically to vaccine, and an update on that all the time, and it's all the time updated. I'm part of a national group that is working ongoingly on that, and there is an aspect on vaccine hesitation and how to address that. It's very good, and again, it's a national group that I am learning a lot, of course, also providing the expertise of nursing, but learning a lot also.
Great. Thank you, Doris. So may I ask two more questions, Dr. Huyer?
Sure.
Yeah. So if you could speak a little bit about children and vaccine, if there's anything you could talk about that. And also, yeah, just start with that one, and then I'll just confirm what the other question was.
Yeah, so from a children and youth point of view, right now, the clinical trials were done in Moderna above 18, or that the approval is above 18, and the approval is above 16 for Pfizer. There are discussions looking at whether it would be a national advisory committee, I believe, are discussing potential use in youth, but in children at this point, the clinical trials are not have not been done, and so there isn't answers on when that would happen. I suspect, and I don't know, but I suspect there will be additional work that will be done with children over the next little while to be able to answer that question as to whether it's safe and suitable for children, but we just don't have the answer right now.
Okay, thank you very much. Actually, Irma Jean just wrote to me to say she has 3 quick questions. Can we sneak those in lieu of my one final question?
3, wow.
3 quick ones, she says.
Okay.
Yes, these are quick. Okay, the first one is, if for some reason you are over the adequate length of time between doses, is that a problem?
So at this point, the monograph says 21 days for Pfizer. I understand it's Health Canada might have approved from 21 to 27. I'd have to double check that, but that's the understanding. And Moderna is 28 days. There have been discussions by scientists that their view is that that there is protection up to 42 days. And so what we are advising is that you strive to get vaccinated on the date through scheduling. But having said that, there is still have been in the trials, there were up to 42 days in some people. So getting vaccinated as soon as possible after would be the best advice, and not mixing the two. So Pfizer, Moderna is what we are advising right now. So hopefully there is a ability to attend at the 3-week period or the 4-week period of time. And if not, then getting it right as soon as possible after.
Okay, and thank you. Second question is, will there be any plans to prioritize those who may be scheduled for medical procedures or surgical procedures and need the vaccination or perhaps should have it?
Not at this time, no. That may occur depending on medical conditions. That may occur over the next period where the phase 2 comes in, but we haven't determined that yet.
Okay, and final question: does one have to be vaccinated in order to be part of the vaccine giving team, or do you get vaccinated prior to giving the vaccine?
That's a great question. And what we have had in many of the sites is that the vaccinators are offered vaccination, and we have made plans for when traveling into remote communities in First Nations communities that the vaccinators are pre-vaccinated, and that's occurring right now. And so there is that planning, but there isn't a mandate for that, but it is something that we have been following in many different settings.
Okay, thank you very much.
Great, thank you so much, Irma Jean. So how about I pass it on now back to Doris for final comments, any calls to action, Doris, and finish the webinar off.
So first to Dirk, I don't know if you have final questions and we didn't scare you away. You kept over 700 people to the end. Here you go. I think your daughter should be super proud of you, as are we, on the capacity to answer all these questions and also to take this mega job on top of what you're doing. I hope that you can keep some time for her and your family. So final questions for you, and then I will give some homework.
I don't have anything else right now. Just thanks for letting me come.
A pleasure. Thank you so much. And if we get additional questions, we may send them to you. And we will probably compose from these questions and answers and run them by you, because I think it may be helpful to people. And we can put them also on the other website that is from several associations. So then for my colleagues, first of all, to thank Dr. Huyer for the generosity of time and for preparing for this webinar and for being able to answer so generously to all the questions that you all pose. To all of you for the work that you do every single day. We know it's a long haul. What I do want to remind you and I know you hear that when I say that in the media, but now I have you captive. There is an end. There is an end on sight. There is a light at the end of the tunnel. It has been a long, long year, and we probably have a few more months to go, but there is an end and the light of the tunnel, so don't give up. And I say this because of what happened with the physician over the weekend. So don't give up, first of all, on trying to rest. Don't give up on thinking that this is like never ending, because it will end. And keep in touch with us, keep in touch all the time. If you have questions, keep sending. If you have concerns, keep sending. This is how we come with events that we do. And please take action. And I'm saying take action when your number comes for the vaccine. Roll up your sleeve, because we absolutely need you healthy. That's the main reason. We need you healthy, and we need to do away with this pandemic, and the vaccine, like it has been for many other conditions, is the answer. In addition, though, for now, do not forget to take care of yourself. The vaccine will come, but for now you need to keep the distance, use the mask every time you get out of the home. That's the way I see it, at least. Wash your hands before you take that mask off, right? And don't go to stores, even if you can. There is no need to be. You can order things online, try to order local. All the good things that you know to keep this province and this country safe and going. So thank you so very much. And to Susan and Olivia and the team that put the logistics of the webinar, and Melissa and Irma-Jean, thank you so very much to all of you for being with us and keeping the logistics so smooth.